Hello, and welcome to McLaren Port Huron's Today's Health. I'm your host, Barb Winters. On our program today, we're going to be talking all about treatment options for individuals that are diagnosed with breast cancer. And in our first segment, we're going to be talking about surgical treatment options with Dr. Kim Clark-Paul. Dr. Clark-Paul is fellowship-trained surgical oncologist with a specialty in breast cancer. Dr. Clark-Paul, welcome to Today's Health.
Thank you.
How do people first suspect that they might have breast cancer?
Well, sometimes people see an actual physical change in their breast. They may see a change in the skin itself. They may have an abnormal discharge from the nipple, or they may have an area of retraction or puckering, or they may feel a mass. So any of those things would cause them to be suspicious. And additionally, on their routine yearly mammograms, which are critical, there may be something that is found that is abnormal on the mammogram.
So once you either have these symptoms or you see something on the mammogram, how do you make a diagnosis?
Well, let's talk about first. So the mammogram may be let's say that somebody found something on a mammogram. It may be that the radiologist will now recommend an ultrasound or maybe even an MRI to better evaluate what they saw on the mammogram. And now let's say that they really did see something that they were concerned about. The way that we typically make a diagnosis, if we can feel the lesion, we can just take a needle, a core biopsy it's called, and do a biopsy in our office. If we can't feel the lesion, then radiographically there are two ways in which we do core biopsies. One is an ultrasound-guided core biopsy, in which the patient comes to the hospital, the radiologist identifies again the area on the ultrasound, numbs the skin up, and takes a needle and goes in and gets a sample. The other is called a stereotactic core biopsy. You see, not all lesions can be seen on ultrasound and on mammography. If it's only seen on mammography, what will happen is then the stereotactic biopsy, the patient lays on a table with their breast through an opening in the table. That area is directly targeted, the breast is numbed, and a needle is introduced, which takes a 360-degree radius then of cores from that area. Now what's very important is once we take the cores from that area, we do a radiograph of our specimen right there. And if we're looking for microcalcifications, we can see, yeah, we got our microcalcifications. And so we can be quite sure that we've actually got representative tissue from the area we were targeting. Additionally, we leave a marker behind so that if we would have to go back and do surgical intervention, that we know where to go in that breast.
So now you have your tissue, and you can, if you make the diagnosis of breast cancer, that the tissue is cancerous, what are the surgical treatment options then?
Let me just go back for 1 minute, because sometimes we will do a biopsy and the tissue, whenever you put a needle in the breast and get tissue from the breast, the specimen will come back as breast tissue. And if the lesion was suspicious, or if the pathology looks suspicious but not enough to call it a cancer, then we will go and do an open biopsy of that area to get the diagnosis. Okay. So once we have the diagnosis, the treatment options, if it's an invasive cancer, the theory is that cancer tends to spread to the lymph nodes from the breast under the arm, and there's another theory that it may already be systemic or throughout the body at the time of diagnosis, but we like to see whether or not it's spread to the lymph nodes under the arm, because that may change our treatment strategy. So we do what's called a sentinel node biopsy, and that's for any invasive cancer basically. So what happens is, in order to identify that lymph node, there is a radioactive substance that is injected around the nipple areolar area, and then once the patient's asleep in the operating room, we'll inject a blue dye around the nipple areolar area. That travels to the first level lymph node, and actually I will show you here. So see, the dye's injected here, and this would be called the sentinel or the guard lymph node. And so at the time of surgery, we will take that lymph node out, and typically I'll send it to our pathologist for a frozen section evaluation. At the time of surgery, we use a radioactive probe detector as well as the blue dye to tell us that we got the right lymph node. And then after we've taken that lymph node out, we check the background of the axilla to make sure that we've gotten all the radioactive material out, because we don't want to leave another sentinel node. Sometimes there's more than one sentinel node. So that, whether we're going to remove the breast or just do a lumpectomy, we would do a sentinel node biopsy.
Okay.
If the sentinel node is positive, plus or minus, we would take the rest of the lower level axillary nodes out, an axillary node dissection. But to answer your question for the breast itself, the treatment of the breast itself would either be a lumpectomy or a mastectomy.
Tell me about the treatment of the breast tissue then.
Well, the breast can either be treated with a lumpectomy, after which the patient will most likely receive radiation therapy, or with a mastectomy. Now with a lumpectomy, if we could feel the spot, then we can just go to the operating room, make an appropriate incision, remove that tissue, and actually I'm using a device now called a margin probe, which helps us evaluate whether our margins are negative right in the operating room. Or if we can't feel the spot, what happens is that the radiologist will put a little needle with a hook to the area of concern, and then we will identify the area in that fashion. Now, if the patient says, I just want my breast removed, then we would do a mastectomy. And the mastectomy, there are several types of incisions, and this is where the oncoplastic piece of it is very important. And we want to remove the breast tissue, and that can be achieved through several methods. One is we just remove the tissue and the patient says, I don't want reconstruction, and we leave minimal skin. Another method is that we remove the entire breast tissue through, it's called a skin-sparing mastectomy, and we make our incision right around the areola, and we take that whole breast mound out through that small circular incision. Then an implant can be placed, and the incision is closed, and then an areola can be tattooed on post-operative. And in some cases, we actually can make a hockey stick-like incision and spare the nipple areolar complex and leave that whole skin envelope. So those are 3 different ways of doing mastectomies, which in the past, we really weren't just doing a basic mastectomy and not having those options for cosmesis.
You've given us so much wonderful information. Thank you for joining us today.
Oh, it was a pleasure to be here.
Stay with us. We'll be right back with more information.